Good afternoon. Welcome everyone to this session. It's the Asian Focal Therapy Update. So I'm Carol from Malaysia, together with Dr. Yung Kan from Singapore and Dr. Peter Chu from Hong Kong. We were together with chairing this session. So for this session, we have total six esteemed speakers with a leader in the focal therapy in Asia that will share their experience, their journey in focal therapy. So shall we start? First speaker? Yeah. The first speaker will be my good friend, Dr. Peter Chu from Hong Kong. He's currently president of the Hong Kong Urological Association. He has vast experience in fusion biopsy, HIFU, and the current one is the transperineal microablative ablation. Dr. Peter Chu, the stage is yours.
Okay, thank you, Dr. Curry and Yung Kan. So it is my honor and my pleasure to speak, to share my humble experience with this new modality. So instead of speaking after all the giants yesterday, I'm going to have a slightly different perspective on the microwave ablation today. Okay, so for those who hasn't come yesterday, focal therapy is basically, I think, not only a bridge, but an important bridge, I think, between active surveillance and radical treatment. Really, in my practice and in Hong Kong, in my place, more and more people are actually considering, active surveillance and focal therapy instead of radical treatment. And particularly those who are actually during active surveillance, once they progress slightly, now we have one more option instead of all go for a whole gland treatment. So this is a long list of focal therapy modalities, which includes the most commonly done HIFU, cryo, and in recent years IRE has a lot of cases too. There are other modalities like photodynamic therapy, laser, focal brachy, which some regions were using that. But now today I'm going to talk about the microwave ablation, which is an emerging, actually a very new option. So the concept of this, all of us when we do focal therapy, I do HIFU and cryo too. But when we talk about focal therapy, an important thing is, of course, the MRI and accurate diagnosis and targeted biopsy and mapping. We all agree to that. But for this modality using the microwave ablation, we actually built up on the fusion biopsy platform. So we use the MRI ultrasound fusion, utilizing the organ-based tracking mechanism. So allowing us to have very accurate biopsy under local anesthesia. Even though the patient is moving around, we can still do a very accurate biopsy. And then on top of that, we'll use the same platform to do microwave ablation. So this is the biopsy machine that I've been using since 2017. This is organ-based tracking technology. For those few who hasn't heard of this, there are different mechanisms of MRI ultrasound fusion, of course. The few of which would be like robotic assisted, like Mona Lisa, semi-robotic assisted, like Artemis, magnetic tracking, initially the Urofair, and one of the BK options have also the magnetic tracking. But now in this Coelius machine, the organ-based tracking is using the pure ultrasound image to track the prostate when you probe and the prostate or the patient is moving. So every single time we put in a biopsy call, or before and after biopsy call, there will be another registration and elastic fusion done. So every biopsy, if I take 20 biopsy calls, there will be 20 times of registration and 20 elastic fusions. So this is the unique feature of this. So this is just an example of a tiny 7mm lesion, which is not very obvious on the T2, but pretty obvious on the DWI and the ADC. And fortunately, only the target was positive for group 2 disease. This is another case that I think the mapping is important. Again, as the MRI may be underestimating the tumor extent, some perilesional biopsy with mapping would be useful. The balls I drew next to the lesions are not really lesions, but the perilesional biopsies, which I labeled differently in different bottles to help me know where should my focal ablation be extending to. So a short message is that the accurate targeted biopsy is very important, and sometimes even the mapping of the systematic biopsies also play a role. So even for the systematic biopsy, I know in some operators or some urologists are only mapping those targeted biopsies. I strongly recommend to map the systematic biopsies too. That actually really helps in the planning. And when we move on to the microwave ablation, on the left side is actually the machine that I use. On the right side, you see is exactly the same, except that there is a microwave generator which is hanging next to it, and I push it into my OR. So the microwave needle is a 17 gauge needle, which is very close to the size of a biopsy gun, 18 gauge. And the treatment ablation zone is increased with the time at a fixed power. So this was one of the photos I took, I think back in 2018-19, where this was done in a lab in France, in Grenoble, and actually in the lab in Coelis company. We looked at the ablation size in meat. Now, just to remind you that, like, actually the reference ablation zone are actually calibrated in meat, so not exactly in a real prostate. But when I think of it, I asked the cryotherapy company, and so how did your reference ablation come out? It's individual. It's not really in real prostates too. So it's just a reference. Anyway, when we apply the microwave ablation, we can either use the mini-grid guidance or the full grid guidance. Full grid, for cryo, I use full grid, if not freehand. But for the microwave ablation, I use the mini-grid, which is actually much more convenient and much better because I can actually insert the needle at different angles, and I can avoid the bulbous urethra. I can, as Professor Okumura said yesterday, we can actually fit the ablation zone to the shape of the prostate better instead of a parallel insertion, which sometimes is overtreat, sometimes is undertreat. So a little bit of, although it's a very new treatment, there's a little bit of evidence and data is there. So there's the first safety trial published a couple of years ago. My good friend, Professor Delanchams in Paris, did the first safety trial. At the time, was a transrectal application. Most of the time, he only applied one ablation, one treatment per lesion, which definitely did not have the margin consideration, but this was just to look at the post-MRI to see whether the ablation was actually covering, or actually the ablation was corresponding to the prediction well, which eventually was, the conclusion was that the complete necrosis was actually achieved in 8 out of the 10 cases, and there was no adverse, significant adverse events in this first cohort. And this is the photo taken recently in my OR. Now we move on to transperineal microwave ablation. On the upper right side is a mini grid. The right lower hand was like a brachytherapy grid. Each works, but we'll see whether it works well for you. So as said, the mini grid is more flexible, and I can, many a time is like mid-anterior or midline anterior tumor, which when I do cryo, I can still do it, but I insert like on both sides of the urethra. But for the microwave, I'll insert my needle right to the center of the tumor and ablate it and hit it hard. And I have no worry of hitting the urethra. And along the treatment, we'll actually observe the change in the ultrasound signal. Now, this is, again, not as clear as the cryotherapy effect, looking at very clear-cut cryo ball, but here we can also see some HIFU-like popcorn changes on the ultrasound, which I haven't really done the analysis, but subjectively looking at this and the 1 week MRI actually corresponded quite well. Where some poor reactions, a minimal reaction we see on the ultrasound actually kind of like predict actually a smaller necrotic zone in the 1 week MRI. So we can actually treat less and more than one lesions. It's actually up to you because each treatment, each ablation is like around 5 minutes. So there is minimal hesitance to not doing further treatment. If there's needed, if you need one more treatment to cover additional margin, it's easy. Just add another 5 minutes. So to it. I hope it works. Can I see my mouse? Yes, it works. So, okay, so we draw the urethra and the rectum. Actually, the urethra is actually more useful because we want to see how much we actually burn the urethra in the process. But if I need the margin, actually I won't care about the urethra because in the first, actually, my data is 30 cases, but I actually did more than 50 cases already now in Hong Kong. None of them actually have urethral toxicity or significant hematuria after I burned the urethra. So this is a midline anterior tumor, inject a needle, and after I inject it, I'll do, just like when I do fusion biopsy, I'll scan it again and then mark the exact location of my needle, which because in a transperineal application of a needle, it is not uncommon that the needle might deviate a little bit. The needle is quite small, and frankly speaking, the degree of deviation might be slightly more than the cryo needles, but the cryo needles are bigger and much more stronger, and it doesn't deviate so much. And okay, so this is another case that I did with the same case with the Gleason 3+4, involving 4 out of the 5 cores here, while the systematic biopsies were all benign. So it's a good case, a small lesion. I did 5 ablations with a center of the lesion and around to have a margin. And this was the day 10 T1 weighted image with the contrast, showing a good ablation. And this is a typical image I see, although obviously not every patient will have the same degree of necrosis. Some have better reactions, some have worse, but I now learned after the first 10 cases to look at the reaction, and I actually adjust the treatment time according to the treatment reaction that I see. So this was the first 30 cases in the first trial on efficacy it's done in Hong Kong in 30 patients, and the primary outcome was actually 6-month biopsy of each lesion. So I include, although I include both low and intermediate risk, but actually most of the case, more than 3/4 of the case in this cohort was actually intermediate risk disease. And for the biopsy, I not only do targeted biopsy at 6 months, I actually do an 18 to 24 core systematic biopsy on top of the targeted biopsy at 6 months. So it's a rather thorough mapping of the prostate after this focal ablation. And the primary outcome shows that like at about 90% of the ablated regions have no remaining cancer. While some of them have out-of-field low-grade cancer, we put them to active surveillance most of the time. In this study, we excluded cases that are within 1 centimeter from the rectum because we don't know how much it would actually hurt the rectum. So we excluded that from the beginning. But more recently, I actually do cases which are closer to the rectum because we can actually, during the treatment, for example, in this case, there's a good reaction. The reaction was so vigorous that I thought, oh, it's running into the peripheral zone. And to make myself more comfortable, I actually inject a spinal needle through a lower hole in the mini grid to put in some normal saline. So basically, it's just hydrodissection, which is done with a grid guidance. But this case, looking back, I probably don't need to do hydrodissection. But I recently do more cases which are really posterior medial, which instead of hydrodissection, I put in a rectal spacer to make myself more comfortable during the treatment. So this is the other Violet trial done by Professor Delongchamps in France, Belgium, Germany. I think around 7 to 8 centers, 65 cases they have completed, and they're waiting for the 1-year biopsy results. And I've opened another prospective trial. It's another single-arm trial, mainly done in Asia, in the Violetta trial, which we aim for 110 men. So and we only include intermediate risk disease with a PSA less than 20. So we just started, I think, less than 10 cases so far. So in conclusion, the microwave is, I think it's an emerging new focal therapy for localized prostate cancer. Is easily done, similar to what you do fusion biopsy with the Khoo machine. And I think it's safe so far. So thank you very much.
Thank you.
Thank you.
Thank you. Thank you, Dr. Chu. In the interest of time, we will leave all the questions to the end of the talks. And we would like to invite the next speaker, Dr. Osamu Yukimura, to the stage. I think Dr. Yukimura is well known to many of us, especially who are interested in focal therapy. He has basically been, I think I would like to say, one of the godfathers of focal therapy in Japan. He is currently the Vice President of the Kyoto Prefectural University of Medicine in Kyoto. And we would like to hear from him about starting the Japanese focal therapy program. Dr. Yukimura.
Thank you so much. It's a great honor for me to be here. I would like to present the history and the principle of Japanese focal therapy program. This is my COI. So actually, this is the most important slides today's talk. As you know, the biggest problem in validating focal therapy is the method of determining the effect of treatment, but it is difficult to compare focal therapy with traditional surgery or radiation therapy. This is important, and we need to cover focal therapy by insurance. This law issue is very important. So that's why we developed guideline for clinical trial to evaluate medical device for focal therapy of prostate cancer by Japanese World Association, directed by myself and my colleagues. This is like USA FDA, in Japanese FDA named by PMDA. We consulted with them and to develop this guideline. This is not clinical guideline. This is a guideline for development of focal therapy device. So that followed of this law, the device can be going to be covered by insurance. So currently, clinical trial is going on several in Japan, but every clinical trial is followed by this device guideline. The same with other US or Europe. In Asia, the prostate cancer is now becoming close to #1 prevalence of male cancer. In Japan, from 2020, it is going to be #1. So in Japan, out of 8 to 9 men will be diagnosed as prostate cancer in their life. For focal therapy, we should know the location of the index region. This is almost, when I was in MD Anderson in Texas, the location of peripheral cancer, location on transition cancer, likely located the anterior of the urethra, not beside the urethra, and the peripheral zone cancer is likely located posterolateral. As you understand this location, the focal therapy may work for peripheral zone cancer to posterolateral region, and the anterior transition zone can be very well work by the focal therapy. And then such an index region can be visualized by multiparametric MRI. This is a historical, very important advance in focal therapy field. And also, biopsy method can be advanced from the random system biopsy. So random system biopsy have a shortcoming of missampling, undergrading, understaging. But now, MRI fusion system allows this technique to more precise biopsy can be made. As you may know, I start my focal therapy in Los Angeles 2012. At that point, I did a hemi-ablation like this. And then when back to Japan, I switched to the superfocal cryo as shown this right side. That is because used to be in this historically, MRI is growing up. When I come back to Japan is actually, MRI is available everywhere. 2 times the number of MRI machines located in Japan than US. That's why MRI-based focal therapy can be easily developed in Japan. That's important background. And also, 3D ultrasound is a very important technology, also advanced with a multiparametric MRI. This is already I mentioned, so that I skipped. And then this is important slides again. Essential step toward establishing a concept of focal therapy, I can say 4 items. One is lesion visualization of clinical skin cancer. This is commonly made by multiparametric MRI, but in future, PSMA PET can be combined with this. Secondly, targeted biopsy with real-time ultrasound image fusion. This is an important step for developing the focal therapy program. Thirdly, establish outcomes ablation or radiation therapy for focal therapy technologies. Fourth, this is also important, consensus for surveillance of untreated area of focal therapy because of focal therapy remain the untreated area in the prostate. Prostates remain so that the surveillance is like an active surveillance. But after the focal therapy, PSA can be normalized, MRI can be normalized, therefore much better confidence by the patients. So patients love the focal therapy compared to untreated active surveillance. Then our important steps in Japanese focal therapy, this is very important advance. 2022, Japanese insurance system allows prostate needle biopsy by MRI ultrasound fusion, 80,210 points. That means 5.3 times more charge than systematic biopsy. The government allows us a more precise, less invasive, biopsy technique is very important in the future. This is a great advance in Japanese focal therapy development. So another aspect is ablative technology. In my experience, cryoablation, HIFU, and brachytherapy, and also microwave is so that I would like to introduce especially cryoablation and microwave, which can be done in Japan. So, first of all, inclusion criteria of focal therapy is very important. Where we developed the clinical trial evaluation medical device guideline, we describe these 5 settings. Focal therapy can be done for initially primary treatments. Secondly, after active surveillance, which is still insignificant cancer, then such an insignificant cancer growing up as a clinical skin infant, at that time, focal therapy is a great therapeutic options for the patients. That's the second one. The thirdly, super elderly people, such as 80 years, 83 years, can be currently hormonal therapy can be delivered, even it is not a radical treatment. Such a patient love this focal therapy, only 1 hour less invasive surgery they can avoid the hormonal therapy based on this potentially radical treatment. And also, salvage treatment after radiation therapy is a very good opportunity. And repeat focal therapy is an important concept. As a TURBT for papillary bladder cancer, we urologists have repeatable. And also, focal therapy of prostate cancer can be repeatable. This is a very important concept. Then, followed by the clinical guideline for medical device, we started clinical trial, investigator-initiated clinical trial of focal cryo ablation, and then last patient out already 1.5 years ago, we summarized such a data and almost submit to the government. I hope very soon Japanese government cover the focal cryotherapy by insurance. This is a pilot study of super focal cryotherapy in our institution in Kyoto, Japan. For example, I could like to share the case. This is diffusion image, very high cellular density index region is clearly disappeared. There is almost no cellular density. The contrast enhanced region disappear by no enhancement sign. This high cellular density area is disappeared. Contrast enhanced area is no enhancement. High cellular density areas disappear as a white region. This pilot study have been done in 5 cases. Clearly, the PSA down around 70% from pre-operative PSA to post-operatively. So PSA is very important serum marker for prostate clinical evaluation test. In case, if there is completely ablated, the PSA is continuously keeping the less than 4. But in case of recurrence or a new lesion like this, PSA over or the 4.0 nanogram of PSA, and likely at this point, MRI can visualize such new lesions. And then we repeat it, and then it's another down, so that we can surveillance like this. So PSA change is very important factors in surveillance of focal therapy. This is our USC in Los Angeles experience. In total, all patients this blue line. But in case of biopsy-proven clinical significant cancer are detected after the focal therapy, as you can see, this purple line, it's increasing gradually. Therefore, after this, above 4, or if likely MRI visualize such a new lesion or recurrence lesion. So similarly, a 50% reduction to 80% reduction of PSA from pre to post. Hamed, it's a London group. Similar conclusion can be made compared to our results. We need friends of radiologists, very important. So we combined research, follow-up MRI data, which I did with the patients. In case of like PSA continue to keep within less than 4, MRI is all excellent data set. But in case of PSA gradually increasing like that, at this point, still no cancer can be identified by MRI, but over 4, this kind of recurrence area can be visualized. I respect the initially PSA 4 is a cutoff of screening, Now, even the focal therapy, this 4.0 nanogram of PSA is a very important cutoff for me to additional salvage treatment can be made, which include repeat focal therapy or other standard therapy. Recently, we conducted another, not only the cryo, but also the microwave and also HIFU clinical trials in Japan. This is a device of a microwave. This is the needle in the tip, the 20 millimeter in length, 60 millimeter radius. This rugby ball shape area can be coagulated by the microwave system. This is an example. This MRI visible Gleason 8 cancer, which intraoperatively Doppler study visualized this hypervasculature area. This is an axial scan. This is a sagittal scan, the same area. Intraoperatively needle delivery, grayscale can be clearly visualize the needle position in axial scan and the sagittal scan. And then start the coagulation, micro bubbles can be created around similar to the rugby ball shape. And then this is the result of PSA change. And patient is happy to maintain the ejaculation and erection and no urinary leakage immediately after the surgery. The focal target microwave tissue coagulation clinical significance cancer, which is MRI visible, is the target. Gleason 7 cancer is all-comer, Gleason 6 large volume, and Gleason 8 small lesion is the inclusion criteria. A surgical technique, including the lesion targeted freehand technique of puncture, 3D mapping of multi-site ablation can be achieved with 5 mm margin of the tumor margin. Follow-up exam can be made every 3 months PSA, every 6 months MRI, and targeted biopsy system were actually combined by when indicated. So at the consent to the patient, we specifically focusing on the patient-specific therapeutic plan for the lifetime. Patient love focal therapy because the functional outcome is good, cancer control is good, and surgical time is short, very short time hospital stay. And also focal therapy is repeatable, and when the whole gland therapy is done, ejaculation is impossible at all, but focal therapy allows ejaculation as well. This future of focal therapy should be very important for the patient consent. Thank you for your attention.
Thank you, Dr. Yukimura. Can we invite you to sit on the stage while we move on to our next speaker? So the next speaker is Dr. Wang Haifeng. He's our urology counterpart from the Urology Department of Eastern Hospital and Shanghai Eastern International Medical Center. He is a professor and director of Urology Department, interest in robotic-assisted radical prostatectomy, template prostate biopsies, multiparametric MRI-based targeted biopsies, and recently he's been doing focal therapy of the prostate with the H-Fire. We'll invite you to give your talk.
Thank you for the introduction, and thanks from the Professor T. It's my honor to be here to talk my experience on the focal therapy. And my title is Extended Ablation Prostate Cancer based on the accurate evaluation of primary and metastatic lesion. How to use? the first, what are the most important things about focal therapy? According to the previous study, patient selection and treatment strategy is the most important things. But I think it's no, because there are two things we have to do first. The first thing is attitude of the patient, because the patient has to follow your advice. And the second one is the evaluation. You should know the real Gleason score, the real TM stage, and the mapping all the cancer lesions on the ground. The third part is the patient selection and the treatment strategy. For the biopsy, you should make a biopsy easy and safe, and no bleeding, no infection, no pain, and let the patient fully understand what you will do on him. As we all know, the transperineal prostate biopsy are becoming more and more popular. Except the pain, transperineal V is far better than the transrectal V. But in order to solve the pain problem, we should use general or spinal anesthesia. So it creates new problems. So to improve the effect of local anesthesia is an important thing. According to the previous study, there are two local anesthesia methods, but I used these two methods, sometimes good, but sometimes no. So I first analyzed the pain of transperineal prostate biopsy. The pain comes from three parts. The first one is skin. So the pain from skin is easy to blocked by local infiltration. And the second one is prostate capsule. I think it can neglect because we do not use anesthesia by transrectal way. So the most important part is the tissue between skin and prostate capsule. Okay. So the first, we do an anatomical study. This is the anatomical study picture. We can see this is anus. This is the midline. The triangle, a red triangle, and the blue point is the previous two method, local anesthesia method. But we can see there is some nerve fiber are not blocked by these two methods. If we move the local anesthesia side to the yellow one, maybe near the nerve trunk, maybe the more nerve fibers will be blocked. And we use neuroelectrophysical study to confirm the site. And after confirm the infection of this method, we organized a single center RCT and confirmed its infection. And the video cannot be played. And the whole process will be carried in a relaxed chat. In order to, okay. After the local anesthesia, we can see we have a chat with the patient. The patient feel comfortable and published on the urology. And in order to make this method popular, we organized another multi-center RCT and confirmed its infection and cited by the EU guideline. And the second step is how to mark or map all the lesions in the prostate. And as we all know, most of the centers have a fusion biopsy system, but some centers don't have enough biopsy system. They use tablet or freehand. In these two methods, according to our data, the total cancer detection rate is there is no difference between the two methods, but in the detection rate of high Gleason score lesion, the tablet prostate biopsy has advantage. For the MRR-based targeted biopsy also very important because the New England article told us that if we plus the targeted biopsy, it can increase the lesion detection rate. And also, if you don't have fusion system, cognitive targeted biopsy is also a choice, but it is difficult to learn. In order to shorten the learning curve, we built a new method and confirmed its infection and have published on AGA. In order to further confirm its infection, we organized a multi-center RCT. 3 months ago, we began this RCT, and until now, there are 10 centers have joined us, and more than 100 cases have been involved. The third step is metastatic lesion evaluation. Plasma PET CT is a very useful tool to evaluate the metastatic lesion. In our center, we use F19 plasma PET MR to evaluate the metastatic lesion. Our data are published in the International Journal of Surgery. At last, for the treatment platform, we use high-frequency electroporation. Its biggest advantage is selectively preserve the nerve and vessel around the prostate, and selectively destroy the prostatic epithelium around the nerve and vessel. And we can see this is animal study. We use dog and ablated guided by the transrectal ultrasound. 2 days later, we get out the prostate. This slide showed us that the nerve and the vessel, the structure of the nerve and the vessel is normal. But around the prostatic epithelium around the nerve and the vessel have been destroyed. After we have got the good result of the animal study, we organized a preclinical study. It gets a similar result. With the good result of animal study and the preclinical study, we organized a multi-center trial. It is a single-arm study, and the inclusion criteria include tablet-guided prostate biopsy or tablet biopsy plus target biopsy. And other inclusion criteria include PSA level less than 20 and clinical stage of T2C or less, and a Gleason score of 7 or less. The exclusion criteria are as following. And the final result showed us that totally 109 cases were involved in 4 centers. And finally, 100 cases were rebiopsied half a year after the surgery. Only 6 patients were found recurrence significant prostate cancer, and 1 infield and 5 after field. And another interesting thing we found is if we divided the patient into 3 groups according to the ablation rate, we find the failure rate and the nadir PSA can be decreased with the increase of the ablation rate. But at the same time, the functional outcome like the sexual dysfunction, IPSS and incontinence did not increase with the increase of the ablation rate. And the result finally published on the JAMA surgery. This is one successful case. This is the MRR before the biopsy. We can see there lesion on the T2 and the DWI, and after confirming the lesion by template biopsy plus target biopsy, we use transrectal ultrasound guide to place 5 needles in and around the lesion. After the surgery, 1 week after the surgery, we do a contrast MRI. We can see all the ablation area or in the prostate, not outside the prostate. And 6 months after the surgery, we do MRI. We cannot see any lesions on the MRI. And the biopsy result shows no residual team. And the PSA decreased from 5.5 to 0.48, and the IPSS and IREF are not in fact. Okay, this is during the surgery. Very easy to do this. Just it is easy for urologists who are familiar with transperineal prostate biopsy. And after, it will take about 10 minutes to place the needle to the right place. And the next step is rest. It is tea time or coffee time. 13 to 60 minutes later, you will come back and take out the needle and place a urethra to the, put a catheter to the urethra. That's all. Okay, 4 hours after the high fire, we can see like this. We cannot see any blood in the urine, and the patient can go around up to himself. That's all, thank you. And also, this is journal, the office journal of Chinese Urology Association, located in my hospital. It is, in fact, is 2.4, and if you like, you can submit a paper. Thank you, that's all.
Thank you, Dr. Wang. Dr. Wang, can we keep you on the stage with us so that we can move along with the program? Thank you. Just have a seat with us.
We keep all the questions to the end of the session. Yeah. So the next speaker with topics of come from Malaysia. I want to invite Dr. Siva. Dr. Siva is currently a consultant urologist and head of department from Hospital Raja Pamasuri Bainon Ipoh. He graduated MBBS in year 2005 and completed his urology training in 2019. Further did a clinical oncology fellowship at Alfred Melbourne in 2021. He's a pioneer for focal therapy in Malaysia. So he will share the experience and the journey focal therapy in Malaysia. Please, Dr. Siva. Yeah.
Vanakkam, selamat tengah hari, and good afternoon to current and future focal therapists. So it's not very much different in Malaysia and the rest of the world. We have an aging population, and prostate cancer is very prevalent with the aging population. And in most other countries as well, it doesn't spare people by race, religion, or your social status. Everyone is involved in this. I'm not sure whether all three of them have visited the urologist, but yeah. And so it got me down to thinking. So we had this paper, collaborative paper, with the Asian CAP registry. It's a multi-center longitudinal cohort study involving 12 nations, Singapore, Taiwan, Malaysia, among those. And between the year 2016 and 2018, we detected almost 2,000 new cases. Now, of these cases, we found that the median age was 70 years. Half of them had major comorbidities. Half of them showed high-risk Gleason scores, and 72% presented with advanced stage, meaning to say only just about 30%, almost 30% present at early stage. And while these numbers were worrying to me, it wasn't disturbing many of my other colleagues or anyone else. So I decided to see, for me, gold standard with prostate cancer treatment is with Australia. And so what is going on in Australia? And in Australia, we noticed that 33% were diagnosed between the age of 50 to 64, 82% presented at early stage. And they were able to achieve a 96% 5-year survival rate. And how did they do this? Because they had effective screening programs done at primary healthcare level, and adequate resources for imaging, and all forms of treatment modalities are available. And this was pale in comparison with what's going on in Malaysia, and likewise in other neighboring Southeast Asian countries as well. So then we've reflected back on what was the treatment landscape in Malaysia. Now the treatment landscape in Malaysia is this: low risk, active surveillance, some even go for radical prostatectomy, radiotherapy. Intermediate high risk, same. Just you have the addition of hormonal therapy. And every sort of treatment has its own pros and cons. The problem with active surveillance, of course, is anxiety. Some of them take it too cool, and we risk losing them to follow up. Radical prostatectomy has its issues because it's a long waiting list in the government hospitals, limited resources for it, cost factor is considerably high, and incontinence and erectile dysfunction, complications that is dreaded by most patients. And radiotherapy, of course, meant for poor surgical candidates, but comes with the problems of radiation cystitis and proctitis and stricture. And there was never focal therapy offered, and the reason why it was not offered, because it was always not recognized as standard care of treatment, and it is not part of the guidelines. And so it is often tabooed off as being experimental. So this is data from our paper, and I just want to focus on these. You see this red column? We are focusing now on stage 1 and stage 2. Now, of these patients who presented stage 1 and stage 2, if you see this group, there's a total of 271 out of 394 patients who were probably overtreated because we did not have the option of focal therapy. Patients who could have got focal therapy were going for prostatectomy, radiotherapy, or some of them just straight went on hormonal injections. And then you have the other group who were undertreated, who were just put on active surveillance when they could have been offered focal therapy. So about 24.3% of them were newly diagnosed with potentially could have benefited from focal therapy, with whichever energy source for that matter. So this, I feel, is a very important slide which got me to understand things. Focal ablation lies between active surveillance and aggressive treatment, surgery or radiotherapy. You have now given patients options to have a pit stop before they even go for radical treatment. So then the question comes, what's the evidence? And in Malaysia, we still tend to follow the EAU guidelines, and that sort of sums up all the available evidence that's there out there. And the current guidelines does say you can offer whole gland or focal ablative therapy within a clinical trial or registry, and it's a strong recommendation. So as we know, HIFU, the concept is pretty simple, straightforward. Just as a magnifying glass can focus the sun's rays to burn a leaf, HIFU focuses ultrasound waves to ablate a tissue, and it spares everything in between. So the concept is very easy to understand. It does not affect tissue in between. Now this is just a video. So I use the Sonoblade, which is the treatment option for HIFU. And this is how the setup is like. And as you can see, you have the console where the main energy source comes. This sonochill is fluid that's running constantly through the probe, transrectal probe and keeping the temperatures down at 16 degrees at all times. Patient is positioned in lithotomy position. There's a stepper, which will then help to mount the articulating probe. And this articulating probe is placed in transrectally. Patient is under general anesthesia, and do not do them with spinal anesthesia because patients can cough, there can be movements, and we want the patient kept still. So the probe goes in, we have a targeted area where we want to ablate, and the first thing that's done is images are taken and saved into a data. So as any other imaging technology does, you scan from the apex right up to the base, and the ablation zones are planned in this manner. So with the ablation zones now being planned and taken up, this is what it looks like. So we have the fusion setting where you can fuse the MRI with your target onto the transrectal ultrasound. Those red dots, or what we call as skittles, are the firing HIFU energy, and they are placed at 3 mm. So for every 3 mm in width and breadth with a height of up to 9 mm, you can find focus energy within these zones. And the beauty is you do it zone by zone. You can start with the anterior, and then you ablate. Once you're done, you can go on to the midland, and then you can go posterior. And the beauty of the HIFU is you can conform you can conform your energy to how you want to shape the lesion in your preference, and you can do it on the opposite side as well. And so far, I've only had 2 patients which I couldn't really offer because they were very anterior and above the 4 cm ablation target zone. But other than that, it's been good. So you've seen the slides in every focal therapy presentation, so I'll skip this. These are just basic grids on how you can deliver the focal therapy, deliver the HIFU. And so this interesting case, which I had one of my early cases, MRI fusion we used for HIFU lesion was just very close to the urethra. And so how do you get past this? You know, you've got a tumor there, and is it going to affect your margins? Definitely you're going to involve the urethra. So we put in a catheter, and then we sort of knew that this is definitely going to hit the urethra. So we did the HIFU. Just before we delivered the energy, we pulled out the catheter and ablated the whole area. And then the concern comes, are you going to cause stricture of the urethra, or is it going to just burn off the whole place with stenosis? But I kept the catheter in for 2 weeks, and this is a video of what it looks like after 2 weeks. So let's focus on the one on the left first. This is what it looks like after the ablation. It looks pretty cooked, and there is sort of a narrow passage. But I went on to do a TURP. And as you can see, on the right, the TURP, I'm using the button with Olympus. And as it's shaving off, you can see all these burn marks and charred tissue very well. And the good thing is I found that there's no profuse bleeding when you're doing this. And the tissue is actually quite firm. It's not soft or mushy as you think it might have been after HIFU. And the patient, I could remove his catheter on the second day, and he pees very well with a Qmax of 26. So why HIFU, and why did I choose this? So the main reason was I had my fellowship training in the Alfred in Melbourne, and it was with Prof. Peter Royce, who is one of the largest users of HIFU at that time. I was unable to perform cases there because of COVID restrictions, but when I came back, I actually contacted the Sonoblade company, and was through LinkedIn. And then we got in touch with their distributors in Malaysia. And then the company sent me on a 2-week training stint. So I did my training with Prof. Hashim, Prof. Carolyn Moore, and Dr. Taimo Shah in the middle there. And in that 2 weeks, I saw enough number of cases with different variations to sort of feel confident to come back and do HIFU. And so we did our first 4 cases the end of 2022. We had a live workshop. Company flew in Prof. Jacob Pang, as most of us know, from Taiwan. And the team that was assembled. We had assistance by application specialists from USA and Taiwan. We did 4 cases and ran smoothly. At that time, my senior colleague, Dr. Sri, was also with us, and he was conducting his observership. And at the end, you get a certification of completion. But to be honest, with 4 cases, you're still a bit apprehensive, and how well are you going to go on? But what I liked about Sonoblade was that there was constant supervision. They flew in people whenever I needed to supervise cases, and that sort of gave me more confidence to carry on. So the next step, what do you do after you have sort of been trained or certified to do HIFU? Then this is the next most important thing that we did in Malaysia, or I had to do personally. I had to write in to the health ministry, and in Malaysia, we have a health and technology assessment wing under the Ministry of Health. So they do an extensive literature review, and then based on a recommendation with the meetings of head of service for urology and oncology, took a 4-month process. We then came with this joint decision for recommendation where HIFU be used for localized prostate cancer, T2 with intermediate risk. And most importantly, I have to maintain a registry as recommended by the EAU guidelines. So I actually maintain a registry now, and whoever does HIFU in Malaysia, I get their data and we put into the registry just to play it safe. And if you're starting new, I would strongly recommend following the focal therapy consensus, right? Stick to the guidelines, stick to the recommendation. Don't try anything, no cowboy stuff. Keep it simple. Visible lesions you start off with. Only do the intermediate grade, and make sure you're comfortable with the energy device you're choosing, and make sure you get good support from the company to get you to do these cases. That's extremely important. Do not offer in negative MRI but positive biopsies initially. Later on, if you think you're doing very well and you're sort of confident with it, then maybe. But when you're starting off, you don't want any form of complications. You don't want any sort of problems. Choose your simple cases and just stick with that. And the more the merrier. I put up all these pictures because these are the important people who got the HIFU running. Most importantly for me is Dr. Sri, my senior colleague. Without him giving confidence, and we sort of gain confidence from each other, even though when we both shitting bricks half the time, not doing what to do. But like I said, the other good thing about the company is that they have this thing called SonaLink. So there is an application specialist who's constantly with you throughout the procedure, connected through Wi-Fi, and they are there to support your case throughout and can actually stop you from making mistakes and advising you as you go on. And every case has been a new learning experience. I learned a lot with every single case. And even when my colleagues, Prof. Dato' Khairul in University Putra, was doing a case, I went down to sort of assist, and Peter Chu was online as well. And even then, I was still learning different anatomies and different ways of treating. And with every case you do, it builds onto your experience, the confidence then increases significantly. And whenever there's someone who's going to do, it's always good to go and supervise, because you know what is being done, and you can save that data for yourself later on. So we've done about 46 cases now. These are our early data. As you can see, it's a bit scary because the patients I had came with significantly high PSAs. This is what I was talking to Peter Chu about. Some of them present with PSA of 26.2. I've done a CTTAP, I've done the PSMA PET, it's completely negative. I'm telling them, no, your prostate PSA is too high. I say, no, doc, please. So, I discussed these cases with Prof. Hashim initially, and he says, the most important thing is patient must be aware, your documentation has to be right, clearly right, that risk and progression, all this has been explained, and if they're agreeable, then you go ahead. And as you can see, patients who couldn't, and some of my patients can't afford transplantation because they have to pay for it. So we did trust biopsies, and those which I was not so confident, I started off doing mostly whole gland ablations, and then later on sort of downsized to focal therapy. Results over the last 1 year. So that bracket, the first patient, his PSA though was 13.1, but he was on dual therapy, so we assumed that the values are twice the value. And what's interesting to note from here is that the PSA doesn't settle down immediately at a baseline at 3 months and then stays on. It sort of fluctuates. And you will find this in any form of focal therapy, I guess, where the PSA tends to fluctuate before it hits a plateau. And so far, these are the only patients who have reached the 1 year mark. Some have done really well. Interestingly, I had this patient who came through a prostate screening session with a PSA of only 1.9, but one of my medical officers had done a DRE and felt a nodule and decided to do a trust biopsy. It was only that one nodule, and it turned out to be a 4+3, and the rest were all negative. So we offered him, and the PSA is not really reliable because the initial PSA itself was not so high. So this guy is on strict monitoring, and he will get an MRI at 1 year, and we will re-biopsy him. And then you've got patients where the PSA starts climbing, but again, I hope that it sort of settles down. And you can see that in general, the drop is at least about 70 to 80%, and that's what you want to achieve. So yeah, the evidence says that the mean time to a PSA nadir is sometimes between 3 to 12 months. The reduction that you desire is between 53 to 84%. I wouldn't accept 53%. Anything 70% and above should be good enough. And you have the infield recurrence rate, outfield recurrence rate. So these are my adverse events or complications. So in one patient, I did the initial patient, which I did a whole gland. I think I did a bit too much towards the base, and he developed like a stenosis and refused any form of intervention later with urethrotomy or even TURP. And he was happy to just go on self-catheterization for 3 months. But amazingly, after the 3rd month, on the 4th month, he stopped catheterization and he was being well. So that was the only initial scare I had. I had 2 patients with UTI, which responded well to 2 weeks of antibiotics. But other than that, it's been good, touch wood. We've got 100% continence rate, 100% maintenance of erectile functions, and no rectal fistula. So the take-home message for me would be that HIFU appears to be a safe procedure with low complications, good preservation of urinary and erectile function. Short-term cancer control is quite encouraging so far. Active surveillance is still necessary for them. Significant number of patients may require a second HIFU treatment, or they may want to do a prostatectomy or radiotherapy. All is still available treatments. If the intermediate and long-term oncological outcomes are verified against the standard of care, which is what we are planning to do, and then I would see focal HIFU becoming a standard of care for well-selected patients. With that, I thank you, and we welcome you to our Malaysian Urology Conference this year. It's being held in Penang. I'm the co-organizing chairman, and hope to see you all again. Thank you.
Thank you, Dr. Siva. Yep.
Okay, so thank you very much, Siva. So the next speaker will be Dr. Yuguan Tang. So Dr. Tang is actually a young specialist in Singapore. He graduated from National University of Singapore 10 years ago, graduated with distinction, and he was actually the gold medalist at the exit examination. And in addition, he is a very keen researcher and has already a long list of publications at this young age. So Dr. Tang, please.
Thanks a lot for the kind introduction. A very good afternoon. So in the next few moments, I'll be speaking whether a robotic platform can truly enhance focal cryotherapy. And without a doubt, we are seeing a rising incidence in prostate cancer. It's the most common cancer affecting males. And actually in Singapore, as of last year, it has now overtaken colorectal cancer as the most common cancer affecting males. And elsewhere in Asia, we are again seeing a rising incidence in prostate cancer diagnosis, even though in this part of the world, we are not doing PSA screening or testing as often as we may wish to. So of course, without a doubt, there's a huge change in the paradigm on how prostate cancer is diagnosed. MRI is now ubiquitous in the workup for someone with elevated PSA. We have better fusion biopsy techniques. And what all this summarizes is that you can now have a better, accurate localization of the tumor foci. And more importantly, we are also looking at how advanced prostate cancer screening is taking place, with PSA making its way into most guidelines or in health screening packages. And this again translates to early detection of prostate cancer, which is potentially a smaller tumor size or burden. And what is actually the most important is the changing patient's expectations. You have the middle-aged guy who is really looking for some form of sexual preservation and functional conservation. And this was shown in our phase 2 study. But more so, we are also seeing a bimodal distribution of patients looking for focal therapy. On the other side, you have really the elderly men who are actually fit. They want to have some form of treatment for their prostate cancer, but something that's probably less aggressive, or I call it the buy-time approach, such that they potentially die with prostate cancer, rather than die from any progression or complications of prostate cancer. And the importance of quality of life is truly echoed by Prof. Ahmed. He actually did a survey across 34 centers in the UK, and consistently he showed that patients of all prostate cancer risk level were willing to trade cancer-specific survival for better quality of life and treatment-associated morbidities. So with that, there's an emerging role and relevance in focal therapy, which I believe is simply a treatment that's born out of necessity. It's here to stay because of the changing paradigms of prostate cancer diagnosis, and more importantly, the patient's expectations. It reduces treatment-induced morbidities associated with whole gland approach and reasonably good oncological outcomes. Surely, we do not have very good randomized control study looking at focal therapy, but if you look at what the experts have talked about, the published data out there, you haven't had a patient on focal therapy who truly metastasized or die after focal therapy because of advanced prostate cancer. And that's something that I think is very consistent in the literature that we have today. So of course, there's a growing evidence of focal therapy in the literature. We started with a systemic review in 2013. At that time, there was only 25 studies looking at about 2,000 patients. It was mostly on HIFU and cryotherapy. We have the overall cancer-specific, clinically significant prostate cancer rate about 20%. You can see about one quarter of them did not perform what we call the post-ablation biopsy. Fast forward 10 years later, now you have an updated meta-analysis. It consists of 3 times more studies and close to 6,000 patients. We now have 8 energy modalities. We have a few randomized control studies. What's important is that the clinically significant prostate cancer rate remains stable at 15%, and most study now has a mandatory rebiopsy protocol so that the surveillance is a lot more streamlined. And of course, in the Asia, we are still a bit slow to take up focal therapy. This was published by Prof. Ukimura back in 2018. He reviewed, and there was only 6 studies that looked at focal therapy, of which only 3 were for primary treatment, and the other 3 were actually for salvage. But I'm happy to say that, for the last few years, there's been a growing evidence. Dr. Chu published, Dr. Wang Haifeng also published a series on focal therapy, and I really think that in this part of the world, we are gaining traction in applying focal therapy for prostate cancer. And of course, we're happy to share that we had a phase 2 prospective study looking at using cryotherapy for intermediate to high-risk prostate cancer. What I really wish to highlight is that the second author, Dr. Law, is a radiologist, and the third author was Dr. Tain, who was a pathologist. And that really highlights the multidisciplinary approach that one should take when it comes to focal therapy. We look at 28 patients, mostly intermediate to high risk, 42 lesions were ablated. We had a mandatory repeat MRI and biopsy protocol between 12 to 18 months. And 6 patients had clinically significant prostate cancer after the biopsy, but suffice to say, many of them were actually small volume that were amenable to a repeat focal therapy, and only 1 patient eventually had substantial multifocal disease that requires a radical prostatectomy. And we look at the functional outcomes using a very comprehensive EPIC questionnaire. again, we can see that there's a transient decrease in your urinary and sexual function at 1 month with complete resolution by the 3rd month. Of course, patients who have a bit more extensive ablation to the ipsilateral neurovascular bundle, they had a little bit more problems with the sexual function, but eventually they do resolve in the next few months. Unfortunately, there are still a few challenges with focal therapy. I think one of the major challenges is that there's a discrepancy between the MRI lesion and the actual extent of the prostate cancer foci. And this echoed in a few studies. Generally, we will say that the discrepancy is somewhere between 8 to 12 millimeters. The MRI do underestimate the actual prostate tumor foci. And this discrepancy may be even bigger if you are looking at a more aggressive tumor with a higher ISUP grade. So the implication of focal therapy is that you always have a chance of risking incomplete ablation and potential infill recurrence if you were to ablate solely based on the MRI size. And then we also look at our own series where we actually look at comparing MRI to the whole pathology of a 70 patient who underwent radical prostatectomy. We were fortunate that the discrepancy was only about 5 millimeters, and we probably attribute the smaller discrepancy to the fact that we have very designated uroradiologists and pathologists that reads the MRI prostate and also help us with the pathology slicing. The second issue is the challenge in inserting the needles for cryotherapy. You know, you can do it either freehand or brachytherapy template. We start off with the brachytherapy template, but we thought it was not really suitable for the Asia prostate that was generally smaller. And for the lateral tumors, that would mean that if you are going with a brachytherapy template, you are more likely to injure the surrounding structures, or importantly, the neurovascular bundle. We move on to do the freehand technique, and if you listen to Prof. Ukimura, what we do is you have to go through to the apical region before you pivot out towards the prostate, the lesion that you want to ablate. I think at the end of the day, with cognitive placement, there's always a challenge. It still has a learning curve. I would say it takes about 20 Ks to really be very comfortable. And we know that with repetitive needles adjustment, there will be hematoma formation, and that really obscure and distort the prostate that affects your visibility and precision of treatment. So with that, it came to my mind whether we should develop the next generation of cryotherapy, which I call it the fusion robotic system. This is simply to incorporate the technology of fusion biopsy into focal therapy. One part of that is that it allows treatment planning that aids real-time correlation between the ablation zone that will happen and also the MRI lesion or the positive prostate biopsy cause. The second is that whether there's an easier way to place the needles for cryotherapy, which is under robotic guidance. And what all this implies is that it allows more accurate ablation coverage, it minimizes injury to the surrounding structures or the neurovascular bundle, and more importantly, it shortens the learning curve to achieve proficiency and allow easier uptake for those who are starting out their focal therapy program. So this is the machine that we're using. I work with the company BioBot. And with that, maybe a video really can speak 1,000 words. Can just get them to play the video. So we start off with scanning the prostate, and subsequently we will segment the prostate and we will auto model. At this part, you can also inbuild the key structures such as the urethra or the rectum. This is what you will see. There are 3 models here. There's the real-time ultrasound model, the MRI model with the MRI avid lesions, and also your prostate biopsy cause. And we do what we call elastic fusion, and after which you can actually identify the areas that has a positive cause. So in this gentleman, he actually 2 lesions, one at the left lateral, which was Gleason 3+4. The right posterior peripheral zone was a 3+3, so we put it on active surveillance. So we're really treating this lesion that was an MRI avid and corresponding positive biopsy cause. And this is where you start planning the needles placement. You can see in the sagittal view and also at the axial view how the ice ball, which is the red, will roughly form. So that will really give you a guidance whether it's close to the neighboring structures or the neurovascular bundle. Okay, so once you're done with the planning, Next is that the software will immediately use robotic guidance to help you deliver the needle placement. So you merely have to insert the needles through the platform into the patient's perineum. So that really makes it a lot easier for the end user. You can see in both the axial view and also the sagittal view, so you can see the placement as well as the depth of it. And with that, we will start the ablation, the cryotherapy, as you can see the ice ball forming over time. So I think the fallback of this is that the planning can only be taking place on the day of the operation. And you know, sometimes it takes a while to plan these cases, especially where you have a larger lesion. So the first few cases for us took considerably longer time. And this is what we feedback to the company, and we work on having a software that allows you to have pre-treatment planning off-site at a computer, and whether, you know, once you are done with the treatment, you can now import your what I call the treatment maps for needle placement, and that really shortens the time in the OR for the patient. And this is the next video that we had a software upgrade where we actually already do offline pre-treatment planning, so we know how the needle should be placed, how the ablation will come up. And what we do is that after importing the MRI and biopsy map, we next also import the planning, the treatment maps for the patient. Yeah, so this is the part you apply your pre-treatment needles. It's already applied there, and immediately you can start inserting the needles. So I think that really shortens the time in the operating theater. Okay, so we did about 8 patients to date. We started this about a year ago, following the conclusion of our phase 2 study. We also have an extended cohort of coming to about 160 patients for cryotherapy. My residence is presenting next door in the oral presentation. You can see that we start off with we took a little bit longer for the first 4 cases because we had to plan them intraoperatively. The subsequent 4 cases we could now do with the pre-treatment planning software, so that reduces the surgical time. So the trial is still open and recruiting, and we really hope to invite everyone on board to join us in this study. And I think leveraging on this opportune platform, we also like to extend the invitation to the Asian counterparts to join us. Really, we are here trying to get more data on the outcomes for focal therapy, especially in this part of the world. And I really hope that following this meeting, we can have more productive publications and sharing of information. So to conclude, I think prostate cancer is a rapidly evolving field, and truly we have an a la carte menu in terms of how we can treat the patients. And for the first time, we can look towards a more patient-centric approach, looking at what they desire in terms of their expectations from the cancer point of view and also their functional outcomes. Focal therapy has consistently showed very promising oncological outcomes, even though we are short of a randomized control study. And this is consistent across many different populations, demographics. And lastly, hopefully with the incorporation of a fusion robotic platform, it really shortens the learning curve and attract more people to start their focal therapy program. Thank you.
We are moving on to the last talk in this session. So I would like to invite Dr. Sally Varro to the stage. Professor Varro graduated from the Adelaide University Medical School, and he specialized in uro-oncology and laparoscopy. And he's a former director of the urology in both University of Sydney and Macquarie University Hospital. And most remarkable is actually he's the founder and CEO of the Metallurgical Innovations company, which resulted in the invention of the Profocal TM cooled laser focal therapy system. So, Dr. Varro, please.
Thank you. Thanks for the introduction, and it's a privilege to be here. It's a very light topic. There's no stats, no randomized controlled trials, so it's a journey. So this is a bit of a story, basically. So if you have an idea, what do I want to do with it? We all have ideas. We're just full of them. We are all in theatres. We want to do things differently. So this is my little journey, and this is what I've done, basically. So thanks for the opportunity of letting me share it with you. So this I thought was a much better topic, but Kajak said, I thought it sounded much nicer and more professional. So I Googled and I said, what does this look like? And I thought, hang on, there's some predecessors of people who've had ideas and started things off in the garage. I thought, I'm in a good company. So when we have an idea and we want to develop something, so I'm coming in from the clinician's point of view rather than a bit of technology given to us, which is different. So when you have an idea, you want to make something, you want to make it to yourself where you think it's going to be perfect for you and for your colleagues, obviously, to make it commercial. So whatever you're thinking about, you can develop, and that's the beauty of inventing your own technology. So in 2013, the most important thing that came to me was we had an MRI machine. We had one of the first ones in Sydney. I was the director of the Macquarie University unit, and we had one of the most powerful 3T machines in that time. We could see lesions. So when we could see lesions, I thought, hang on, the prostate is in exactly the same field as the rest of the organs at the moment. There was no ideal technology available. So when you don't have anything and you're thinking about, well, I can see the lesion, I can target it, but I want to do something with that lesion to make it a partial or focal therapy. Focal therapy was very novel at that stage. And the solution, well, make up your own. Easily said than done. And it has to be prostate specific. So 2013, we started the first prostate diagnostic centre in Australia. I was director at that stage, in view of basically doing a pilot study of in-bore MRI therapy as well. Well, we could target, we can biopsy, the technology shouldn't be that far off. And after the second case, I thought this is very interesting. So I thought, well, if I can target, I can treat, and we knew that the natural history of the disease would allow us to do so as well. I started doing things in my garage, and this is my garage. Let me just focus a few things here for you. So it's not a big garage, that's the first thing. So I don't have much space. You should notice three things on this. The table is my university table that I basically had to use from med school. The next thing is that Elon Musk would be very happy because I was using his bonnet as a table just behind me. And the third thing is that there's just below there on the bottom of the table, there's a glass of empty red wine. There was a lot of red wine being drunk most nights and most weekends just to keep it entertaining for myself. So the energy sources at that stage I felt just weren't quite right. They were adopted technologies as they are, and they weren't specific for the prostate gland, and the limitations are, as we know, are still being discussed at the moment. The challenges is the anatomy, the proximity to the adjacent organs, preservation of those, and obviously the a la carte approach which people still talk about, that we need multiple energy sources to treat the whole gland. So people talk about the anterior zone being IRE, cryo, posterior HIFU, somewhere in between you might do something else, and the apex is usually brachytherapy. And that's not very practical. Most urology centres would be lucky to get one energy source at best. And the next thing you would do, you end up selecting your patients out relative to the energy source that you have. So suddenly 20, 30 or 50% of your patients who could potentially have focal therapy can't get it. So if you want to age quickly, do this, take the journey, but it's fun. So the first thing that happened this is the Ministry of Health, and this is the Health Minister, I got awarded a grant, and I'm not sure how and why I got the money. I think it was because I was a doctor, urologist, I had an idea, and it was literally at the idea phase where I got some money and everything became real. I thought it was a bit of a hobby in the garage. So when the government gives you money, you have to show something for it. So you start getting smart people on board. You need engineers, lots of engineers, very smart people, and the list goes on and on and on. I could put just slides of people and people that you need in regards to developing a bit of technology. You start building a clean room, you start manufacturing, and then this is all after you've done some benchtop testing, animal testing, and then you start doing a trial. This is many years down the track. So my wife was nice enough to say, well, you got some money from the government, they believe in you. She said, I believe in you as well. Why don't you come inside the house now? So I got upgraded to the attic laboratory. I would suggest that you don't have a laboratory in your own house because this is used to be the kids' play area. because you wake up 4 o'clock in the morning and you have an idea and you just have to test that idea, and it happens over and over again. So you wake up and you start doing some ablations. And it takes quite a few years. I was also working with some engineers at this stage, and I would go to incubators, or what we call hot seat research labs, if you like. So you're looking at a focal therapy, you want to invent something, and you want to invent something that's versatile. So what do you want to do when you want to invent something? You look at the limitation of what's out there, and you want to correct that, basically, improve on that. There's no point in making more of the same. So you want to be able to treat all areas in the prostate gland, not the posterior, not the apex. So your technology should be able to address everything. It should be effective. So you want to have something that's, doesn't do it most of the time, but it works every single time. And you can retreat if you want as well. It should have no side effects, or very little, because it is new technology, it's minimally invasive, it has to be better than what's out there. And at the end of the day, if it has any commercial impact, it needs to be quick, effective, safe, and it should be something the residents could do, just literally by see one, do one. Because that's how we teach urology. And this was a bit of a learning for us as well. If it didn't work, you didn't select your patients well, or the cancer came back, there should be no concerns in regards to the operation afterwards. You shouldn't be worried about it, like we would do with radiotherapy, for example. We don't want to operate afterwards. So your focal therapy should not be a barrier to offering an operation without thinking about it. So this is pretty much what the culmination of 10 years of interesting hard work is. It's a single needle applicator that we developed. It's a very high pressure cooling system. So the pressure system inside the cannula is about the same as your tires in your car. It has a dual point ablation system, so the tip is where the ablation stops, and 20 millimeters, it's fixed every time. You can dial it up, you can dial it down, so you have control. You have sensors on it, so you know what you're getting every single time. And at the end, depending on where you place the needle, you can determine how much you want to ablate. So you're in control. So it's quite unique in that sense, but it's also engineered to be like this. You need to be able to determine if you're close to the rectum, because you want to be really close to the rectum, because 70-80% of the cancers, as we know, is near the peripheral zone, it's near the apex. So when you place the needle, you want to ablate all the way to the capsule. So you can dial it up, depending how close you are, and you're going to get the same ablation zone every single time. And the distance is fixed. You're not going to go 25, it doesn't go beyond the tip. So if the cancer's near the base, you make sure that the tip sits on the base or just beyond it. It doesn't go into the bladder. And the same thing happens at the apex. So when you start developing the engineer, you have to set up a clean room. So when you manufacture, you don't do this on the kitchen bench. So you need a team. And this is the manufacturing place that you need for a medical device. This can't be outsourced. This is something that you're trying to still develop. It's early phase. So you have a clean room, and we have people developing and building the catheter. So it's all built in Australia in-house. And I guess when you have a bit of piece of technology, the next thing is you need to do a phase 1 or pivotal trial to see whether it actually works. It's nice doing it on the bench, animal studies, and now this is the acid test. So first thing, as I mentioned, can we treat anywhere? And this is how we started off. We thought we have a very good controllable piece of technology. It should be safe to treat anywhere. My colleagues suggested at that stage maybe we should put a spacer on at the posterior aspect, inject, and we decided if it is really as good as it is, we should not need any. And we never used any spacer at all. So anterior tumors, you can treat right to the apex. So you can circumferentially, because once you've placed your needle, you know what you're going to get from the ablation zone. Posteriorly, near the apex, it stops. You're protecting the rectum, you're protecting the neurovascular bundle. You can sculpt. You can basically go around the lesion and get your margins as you wish. Anywhere you like. You can do very big prostates. The concept is if you can transperineally target and biopsy the cancer, then the technology should be able to reach and treat the cancer as well. Large prostates, postular, these are the easiest ones to treat for us. Literally, this would take about 20, 30 minutes. Is it effective? It's nice that it actually gets you nice MRIs afterwards. The proof is that we need to do biopsies afterwards. And that's what we did. We biopsied all patients that came through, bar one. So this is a 99 out of 100 patients who got the biopsies. And we divided them into two segments. The first 50, where we learned a lot about the technology. We changed the technology. Having your own company, it allows you to pivot quickly and make small little changes along the way. And that's the beauty of what we had. And the beauty was at the end, the last 50 patients had 92% no significant cancer in field with one treatment. And we didn't do second treatment for any of our patients. It wasn't part of the trial. Well, how did we go from a side effect point of view? Literally, these patients looked and felt just like a TP biopsy. Initially, they had a slightly higher urinary tract infection because we catheterized them, because we weren't quite sure what to anticipate. After our first 10 patients, we stopped catheterizing them as well, and we were quite happily surprised they could void. We also noticed that there was a slight dip in the potency, and I've been speaking to Professor Okamura with this technique of going from an angle, because most of these were done with the BioBot from our previous speaker, but half of these cases we actually used the BioBot system, and then we went on to a template. Now we've moved on to doing freehand, and I think the Apex technique is very nice. There was no stress incontinence in any of the patients. We've done almost 300 cases since, and there's still zero incontinence. We just don't seem to be able to make anyone incontinent. Not that we're trying, but it's just how it is. There's no fistulas, and it seems to be something that's how the technology works. It's just different. And it's most likely because it's controlled. So we know what we're getting. When the needle goes in, we know what we're ablating. So this is a debate, and this is a bit of a spreadsheet, if you like, of graphs of the focal therapy. So this is a debate just recently in Paris, where I was debating for focal therapy versus radical treatment, and I did a deep dive into all the opportunities. And the most important thing that stood out for me was we aren't doing that great with radical surgery. I think we know that. That's why we're all here doing focal therapy and thinking about focal therapy. We're not as good as from a functional point of view. And when I compared my focal outcome in regards to what is out there at the moment, I think I achieved most of those goals in regards to what I wanted to with designing the technology. This is the design, this is the final system that we have. It's got a temperature integrated system, a cooling mechanism, a laser unit, as well as a screen for measurement and displaying everything we need to do with it. So thank you so much for your time. This is my little journey of my little experiment, which took me 10 years.
So thank you very much, Dr. Vero. We would be really, we really love to have some Q&A, but unfortunately, I got direction from our head that we have overrun a bit, and I guess the speakers will be very, very available at the tea time to answer your questions. So thank you very much for attending the session. Thank you.